So our speaker is my wife, Dr. Rita Raverty. She's a board-certified family practice physician in River Falls at the New Alina Clinic. And she is going to talk to us today about shared decision-making. And I'll hand some stuff off.
Am I good right here?
No, you want to go over.
I want to go over there.
Front roll. Go to the camera. Say hi to Mom while you're up there.
I don't care that. I don't care that. Well, thank you for having me. I actually love doing stuff like this. For those of you who know me, you know that I like to talk. And so, but I also wanted to make this kind of interactive and leave some time for questions and discussion because I think this is a topic that lends itself well to discussion and conversation. So, shared decision making. I'm going to start with a story, okay? So I like to sometimes, if I get an extra hour, like park myself down in a cafe down in River Falls with my little computer and sit away from the hospital and away from the clinic and do a little bit of paperwork and catch up on things. So I was sitting down at C'est La Vie one morning and I had my computer out and there was a group of ladies in front of me and they were talking about healthcare. And this isn't unusual, you know, people get together and they were talking about healthcare. And specifically, they were talking about colon cancer screening. And they went around the group, and one of them said, well, my doctor said I need a colonoscopy every 10 years. And I'm like, well, my doctor said I need a colonoscopy every 5 years. Well, my doctor said that I don't need a colonoscopy at all. My doctor said that I just need to do those stool blood card things every year, and that was good enough. Why can't these doctors decide what the right thing is? And then, of course, one of them caught me at the back of the room, and she's like, ah, Dr. Raverty. And I'm like, oh, here you go. Why do we get all of these different messages from our doctors? Why can't they just make up their mind what the right recommendation is for cancer screening? What do you think is right? And I said to them, I said, well, I can't tell you what's right because what's right for you might not be right for you, might not be right for you. That decision depends on the person. And this is a conversation that we have as physicians. So then, not long after that, I went to a conference and they introduced this term, shared decision making, and they had a whole talk about shared decision making, this new concept in medicine, shared decision making. I'm like, well, that's interesting. This sounds like a good new concept, something to talk about. And I sat down and they introduced this. A process of communication between a healthcare provider and patient that incorporates the patient's values and preferences into the decision-making process, thus putting the patient at the center of his or her care. And I thought, that's what we do every day. And that's what a good family doctor, a good primary care doctor should be doing with their patients every single day. And for those of us who've been doing this for a long time, 21 years for me, this is something that we really value. And it seems like just recently, kind of the healthcare thinkers have caught up with what we try to do. We try to bring what is best for the individual, including their values, into the decision-making process. So back to the ladies who are sitting having coffee in the morning and bemoaning the fact that each of them got a different bit of advice from their doctor. The answer is probably they're all right because it really depends on what you value for your health care. So what I thought I would do today is talk a little bit about some of the most common screening that we do and how shared decision making, give some examples of how shared decision making works into the process of deciding what's best for healthcare screening and to give people kind of a construct to talk to your physicians about, and so that people can talk about this when they hear people out in the community saying, why do the doctors not agree on what's right? It's because there isn't a one-size-fits-all in medicine, nor should there be. So every time they're like, well, this is what you should do, those of us who tend to be a little contrary will push back and say, well, that isn't one size fits all. Does that make sense? So I listed a few things on the bottom of the page of what are the most important parts of your health care. Prolonging life, alleviating pain, accurate communication with families and loved ones, emotional support and alleviation of anxiety, continuity of care, making sure that you can get care everywhere from locally, Prescott, River Falls, Ellsworth, all the way to the big city. If you need other care, make sure everything is continuous, respect for religious values, maintaining independence and autonomy. I hear that a lot. People don't want somebody else to have to take care of them. One that I left off of here, and I thought about quite a bit when I was thinking about screening, is cost. I mean, and it's foolish for us in this day and age with the cost of healthcare. We were just talking about this, the cost of insurance and deductibles. Cost, whether you like it or not, is a determinant of how you choose to get your health care. Did I leave any out? Anybody else is valuable? So, shared decision making, I left a flyer out about lung cancer screening. Lung cancer screening is really when this is a relatively new recommendation for screening and screening options. Until about 2 years ago, there wasn't a recommendation for lung cancer screening. Because there was no evidence that screening for lung cancer actually prolonged life. And there was some evidence that doing chest x-rays every year, things like that, that exposed people to radiation actually increased your chances of lung cancer. So it's never good to do a type of screening where you're actually increasing the people's chances of getting lung cancer. So now with new technology, we can do CAT scans that have less radiation exposure. So there's actually really good evidence that screening for lung cancer can prevent disease and help people live longer. So as part of the lung cancer screening guidelines, the concept of shared decision making, that's where it was born with our lung cancer screening recommendations. And here's why. So lung cancer screening is complicated. Most of us who do this, who've done this for a long time, still find this a little cumbersome to talk with people about because you have to meet certain criteria. You have to be between age 55 and 80. You have to have a 30 pack year smoking history. What does that mean? A pack per day for 30 years. You have to either be a current smoker or have quit within 15 years. And you have to have no signs or symptoms of lung cancer, like, a bad cough or unexpected weight loss. So let's say you were a heavy smoker for 30 years and you quit 5 years ago and you think, oh my gosh, I'm at risk for lung cancer. Doc, what do I do? In the old days, we used to go, kind of cross our fingers. If you develop bad cough, you start coughing up blood, then come and see me and we'll get a chest x-ray and maybe it'll be there, maybe it won't. But now the recommendation is we talk about low-dose lung cancer screening. The interesting part of this is in order for where it comes to cost, insurance companies to pay for lung cancer screening, they want you to have a specific visit for shared decision making. So that and you have to actually document all of this. That you talk to people about, these are the criteria for it, here's the protocol, you go in, you have the CAT scan, and you go over the results. And that's where things get a little bit complicated and hinky. Technical term. So for those of us who grew up in this area, so I grew up in Lake City, Minnesota, people here in Prescott, you might not know it, but we're all at high risk for a low-grade fungal infection in our lungs, something called histoplasmosis. It really likes the Mississippi River Valley. And that causes all kinds of nodules, scar tissue in our lungs. So if we had histoplasmosis as a child, probably never knew it, but it can show up as nodules in the lungs. So then you go looking for lung cancer screening, and lo and behold, they find nodules. Now what, right? So depending on the size of those, some of them can just be watched, some of them have to be biopsied, sometimes you need another CAT scan in 6 months, sometimes you need another CAT scan in a year. So when people have this, they need to know that, especially when we live in this area, they're gonna find something. Now, I can't remember the last time I saw a chest CT that they didn't find something. And so then you say, okay, Rita Raverty, what would you do? They find a little nodule in your chest. Okay, that's gonna create anxiety, right? It's gonna cause worry. It's probably gonna cost extra money because now it's not screening. Now if somebody has to go put a needle in that, then that's gonna cost more money. And then what if my lung collapses because they put a needle in my lung? Now I have to go in the hospital. So before you do this screening, they want you to understand, okay, what's going to happen if you find something? Because the worst case scenario is you find something and you say, oh, I don't want to do anything about it. So then you're left with the worry and the unknown about this. So this is where when they developed this screening guideline, they said, we need to educate people. We need to have a specific shared decision-making visit. Because some people, when they hear all of this, all of the things that can happen, and knowing that they're going to have follow-up scans, and they might have to see another doctor and have biopsies, they say, you know what, I don't want to do it. And that's an okay decision, because what my decision might be would be very different than what my dad's decision might be, would be very different than what my sister's decision would be, but it's all okay because it's up to their own values about what they want to do. And more in healthcare, they're saying we need to have those kind of discussions. We need to take into account what people want for their healthcare, because there are risks, there are costs, and people need to know that before you just start ordering a bunch of tests. Does that make sense? Any questions about the lung cancer screening guidelines and how all of this came to be?
Is there anything in the guidelines that says like if you have a history or hereditary that you would qualify?
And that would be, so not in that one in particular, not in the lung cancer, because lung cancer is so clearly related to smoking. But in some of the other guidelines, there are. And this is where those changes can come, so absolutely. So then in your packet, I included some very medical heavy things. Not that I'm expecting that people understand these, and we're gonna kind of go through and talk about these in terms of shared decision making, but more for illustrative purposes, because these will tell you, if you start with the colon cancer screening one, that nobody agrees on what's the right screening protocol, okay? It all depends on who you ask. So if you ask the United States Preventative Services Task Force, they'll give you one recommendation. If you ask a gastroenterologist who does colon cancer screening for a living, they'll give you another recommendation versus the American Cancer Society and the American Academy of Family Physicians. Even doctors and medical societies cannot agree on what the correct frequency and when to start cancer screenings. So specifically with colon cancer screening, probably, I love getting medical information from the news. You've probably seen that there's some talk recently about starting colon cancer screening. Typically we start at age 50, but moving that routine screening to age 40. And just because we're seeing more and more cases of advanced colon cancer in people who are less than 50. So if we're seeing more and more of that, maybe we should be starting to screen earlier. And that's kind of a hot topic right now, and I think one of the societies has gone to starting at age, and the American College of Gastroenterology, screening should begin at 45 years of age in people of African American descent, and I think that's appropriate. So just some illustrations of the difference in recommendations. So this goes back to what the ladies in the coffee shop were saying. So for the average risk person, meaning they don't have any symptoms, they are not Black, they do not have a family history of colon cancer in a first-degree relative, meaning a parent or a sibling, they don't have any underlying diseases that put them at risk for colon cancer, like ulcerative colitis or Crohn's disease, those people should start colon cancer screening at age 50. So anybody else, say you had, your father was diagnosed with colon cancer at age 52. You should start 10 years before that. So that's why it's not one size fits all. And then rather than having screening every 10 years, your screening should be every 5 years. If you've had a precancerous polyp, then that puts you in a different category. So asking people to say, well, what's the one right thing to do? There is no one right thing to do. This is why your healthcare provider should be having a discussion with you about what your history is, what your family history is, what your values are, and what you really want to do. And then the other question is, well, when do we stop? Okay, and this is, I hear this a lot from my patients. My doctor said I didn't need to have mammograms anymore. What kind of nonsense is that, right? And this is where, and you'll see there's a mammogram one too, because there's just as much controversy about mammograms, like when to start, when to stop. And my answer always is stop screening when you would stop treating. So I have some women who are in their 80s that I take care of. I actually take care of a lot of women who are in their 80s, and they'll come to me and they say, my last doctor said that I didn't need mammograms anymore after age 75 or after age 80. What do you think? And I say, well, if we found something on your mammogram, would you want to treat it? Well, absolutely I want to treat it. Take it out. I'm like, well, then we should go looking for it. And I have people who are younger, who aren't in good health. They have heart disease, they have diabetes. I don't know that they would survive treatment for cancer, you know, with surgery or the chemotherapy or the radiation. And so if I've got a 62-year-old lady and she's not physically well enough to go through cancer treatment, I'll tell her, you know what, you don't have to do mammograms anymore, because if we find something, we probably won't treat it. And if she says, oh, I'm not comfortable with that, Dr. Raverty, I say, okay, you know, that's your choice. And it is, it's up to you. So I have women who are 85 years old who are still doing their annual mammograms. And the reality of it is that if you're 80 years old as a woman and you are in good health, you don't have diabetes, you don't have heart disease, you can expect to live and live well independently for another 15 years. So treating a breast cancer, an early stage breast cancer, will prolong your life and your quality of life. But that might not be true for somebody who isn't completely healthy. So when you're making that decision to screen or not screen, you should be doing it together, taking into the patient's values. It comes into effect on the other end too, like, well, when do I start breast cancer screening, right? Some societies will say 40. It made a big stink in the medical society when the U.S. Preventative Services Task Force, meaning the government, said that we shouldn't do mammograms before age 50, which I personally disagree with. They did that mostly on the basis of cost. They look a lot at cost per life saved, which, yeah, I see that, but this is where my values are getting in, because I disagree with that. And so they'll say we shouldn't do mammograms at all before age 50. For those of us who take care of people, and have seen plenty of cases of breast cancer in women in their 40s, and have first-degree relatives who had breast cancer in their 40s, I have a really hard time swallowing the recommendation to not do mammograms before age 50. Some women say, oh, I don't like the idea of the radiation. I'm like, oh, that's a valid concern. So when we say, okay, well, if you don't like the idea of radiation but you still want to be screened, maybe we screen every other year. There's no right or wrong about that. Does that make sense? Yes.
How flexible are insurance companies?
Good question. And this is where money comes in. So, and it depends on the type of cancer screening. And these are things that most of your physicians, healthcare providers should know. If it falls anywhere within kind of anybody's recommendations, usually they will cover it, okay? So, and this has changed over the years. So mammograms, pretty much universally covered. I've never seen a screening mammogram decline, just because there's a lot of, it would look really bad if they said, no, we're not going to do a screening mammogram. If you were 35 and didn't have a family history and said, I want to do a screening mammogram, they might not cover it. So if it's clearly outside of any of the recommendations, they may not cover it. Colon cancer screening, when I first started practicing, the government, meaning Medicare, did not cover colon cancer screening. They did not cover screening colonoscopies. They didn't even cover physicals for people who were on Medicare. That has changed now, and there's typically really good coverage for most well-accepted screenings. Same thing with prostate cancer screening. I've never seen those declined either. So if it falls within any of these recommended, most insurance companies are really good at covering it. Now, let me give you an example of where people might get a little bit sideways. And I get this question a lot of like a screening test versus a diagnostic test, because people will end up, I see people nodding, where we'll end up having a colonoscopy, and they'll say, well, my insurance didn't cover it, it goes to my deductible. This is a screening colonoscopy, why wasn't it covered? So this happened not long ago. I had a patient who said, you know what, doc, I don't want to do a colonoscopy, I can't take a day off work, I hate the idea of the prep, can't I just do that new Cologuard test? I've seen this on TV. Now I can just send in a stool sample, it's good for 3 years, fantastic, I don't have to take a day off of work, my insurance is Blue Cross Blue Shield, I know they cover it, can I just do that? Absolutely, you can just do that. So she did that, and then her Cologuard test came back positive. So if her Cologuard test is positive, it means that she has a higher chance of having a precancerous polyp or a colon cancer. So then she needed to have a colonoscopy. At that point, her colonoscopy is not a screening test, it's a diagnostic test. And all of your insurance deductibles will apply. And so she ended up having to pay her deductible for a diagnostic colonoscopy versus if she would have just done the regular colonoscopy screening in the first place, it would have been paid for as a screening test. So this is where, when I said initially that cost comes into account for a lot of people. Most insurance companies will pay for things, but then the question is back to my lung cancer. What if they find something? If they find something, then we're out of the screening realm and we're into the diagnostic realm, and then all of your insurance deductibles and everything apply to that. And so some people, when they hear that, they just say, I don't want to go there. I'd rather not know. And it's painful for us as doctors to have people making choices about their health care based on what their insurance may or may not pay for or having to cover their deductible. But unfortunately, that's kind of a reality of the way our system is right now. So, does that answer your question? So, let's talk a little bit about prostate cancer screening, because that's the same. So lots and lots of changes. Again, depending on who you ask, some people say don't do it at all, some people say yes, you should do it. This is one where there's when I first started practicing, it was PSA for every man over age 50 every year. And now we know that for many people, many men who had prostate cancer diagnosed and then they had surgery for it and all the complications that can come with surgery, like impotence and difficulty with urination, for a disease that tends to be slow growing, and most men don't die of their prostate cancer. Even if they have prostate cancer, most men will live long enough to die of something else other than their prostate cancer. So you'll see on that list that many different organizations recommend not screening for colon cancer at all in people who aren't at risk. I talked to a urologist not long ago, and I understand that they have a different perspective because they see people with long-term, they see people with severe colon cancer that have issues with metastatic colon cancer, people who are dying of colon cancer, prostate cancer, and they see people dying of prostate cancer. And they say, oh, we should be doing more screening for prostate cancer. So this is one that is really a hard discussion for me with many men, because you might very well find something with a PSA screening for prostate cancer, and if you find something, it means painful biopsies, lots of follow-up, and a lot of things that we're doing procedures for a disease that probably won't kill you. So the question is, what do you want to do? And some men say, you know what, I had this happen just the other day. One of my best friends died of prostate cancer. It terrifies me. I really, really would be willing to do all of this. Absolutely, we'll do the screening. If something comes up, we'll treat it. And I had another man who said, I had a good friend and he ended up with having his prostate removed, and he was incontinent for the rest of his life and dependent on other people for his care because of complications of his surgery. I never want to do that. I don't care if I die of prostate cancer. Absolutely, your choice. So prostate cancer screening is one of those things. Boy, we have these discussions every day because it's completely up to people whether or not they want to do it. There's absolutely no right or wrong. The only time I really push people for it is if they have a first-degree relative who had died of prostate cancer. Say you had your father, and we'll see this, it does run strong in families. Grandfather, father, brother all had prostate cancer or died of metastatic prostate cancer. Then I push people hard to do it. But again, still up to them. Does that make sense? Okay. What else did I want to talk about? Oh, and breast cancer screening guidelines. Again, it's all over the board. We touched on that a little bit earlier. That's one that we have kind of, there's no question that doing annual mammograms between age 50 and 65 reduces your risk of dying of breast cancer. So that one, that's an easy one. It's typically the questions are, what do you do between age 40 and 50, and what do you do after age 65? That's where you have a big divergence in opinions on breast cancer screening. So, is that helpful?
Rita, I see information out there on 3D
Yep.
mammograms.
Yes.
But I went into Lina and I tried to make it over in Hastings, but we don't have one there. So is this something that's coming everywhere?
It is coming everywhere. And so mammograms are kind of like, as far as all of our like radiologic screening modalities, mammograms, like a standard mammogram, pretty old school. And they haven't changed since like the 1950s, you know, like some stuff. 3D mammograms, that's the wave of the future. And I think you'll see within the next, within the next 5 years, Alina will replace all of their mammograms with 3D mammograms, which are more sensitive and specific. So we have fewer callbacks, fewer false positives. You know, people aren't being called back for a little lump that turns out to be nothing.
Is the process the same?
Yes, the process is exactly the same. We should actually have ours installed in River Falls by summer.
Yes.
So,
But like my insurance only covers a 2D.
yes, and that should change too. And this is what happens, is like sometimes our technology moves faster than the insurance can keep up with, and then people start making a stink and it becomes the standard of care. So a lot of times it'll become the standard of care, and this is exactly what we're seeing with mammograms. You know, it's very quickly going to become the standard of care that 3D mammograms are there. And the insurance companies tend to lag a couple of years behind, and it creates a lot of angst for us. This happened with colon cancer screening too, where it really became the standard of care to do a full colonoscopy. And for a long time, a lot of insurance companies wouldn't cover a full colonoscopy. They'd cover a sigmoidoscopy, or they'd cover, you know, the stool blood cards. But then pretty soon it became really obvious that it was the standard to do a full colonoscopy. And now every insurance company will pay for those. But yes, that's coming. And these things will probably change again. And we saw that with, I didn't include this, but with Pap smears. So 20 years ago, we did old-fashioned Pap smears for cervical cancer screening. It was just cells on a slide like this, you know, kind of sloppy, really old school. Look at them under the microscope, make your best guess. And then the technology changed. And now we have thin prep, single layer, really nice Pap smears, and they're a liquid-based Pap smear, and for a while a lot of insurance companies wouldn't pay for them. Now they're the standard of care. I can't remember the last time I put a Pap smear on a slide. The nice thing about that is it actually saves money in the long run because it really only has to be done every 3 years when it's that much better, the technology, versus every year to do the old slide pathology. But in the time between when the technology changes and the recommendations change, there's always a gap between then and when the insurance companies catch up to. And that goes along with HPV testing now, because a lot of insurance companies won't cover standard HPV testing on your Pap smears, and I think in the future that's going to be the absolute standard, but it's expensive. So, but if that's negative, then you can go from 3 years for a Pap to 5 years for a Pap. So in the long run, it saves some money, but it takes them a while to figure that out.
For most of these testing and et cetera, do they look at the, what you call the family level, whatever, what you
The
call
family
that?
history,
The first level, immediate family, or do they look at that and then maybe cover?
the insurance company, the insurance companies won't look at that. Sometimes, and it'll depend on the insurance company. Some insurance companies will pay for it every 5 years and they'll pay for it if the doc orders it. But a lot of times what we have to do is on the front end, while we're getting authorization to do, say, a colonoscopy, why has it been five years instead of the standard 10? Well, my mother died of colon cancer, okay. So sometimes we have to actually submit that information to insurance companies on the front end. Sometimes they deny it, and then we have to go back and say, no, this is why we did it. And I think insurance companies like to just make us jump through those extra hoops sometimes just because they like to annoy us. But sometimes, yes, we do. We have to appeal to them and say, this is why we're doing this. So
we should ask that question, is this a diagnostic test or a screening test?
yes.
Physician schedules?
Yes, and most things, and so it's an easy way to think about it, is if your doctor found something, like if you have, take for example colon cancer screening, if you've had blood in your stools, or you've had profuse diarrhea, any bowel symptoms, and the symptoms are why they're doing the colonoscopy, it's a diagnostic test. So most things will not be considered screening unless you have no symptoms at all. And it's purely a test. I don't have any. So if you've had a positive stool blood test, those little cards that we send out, if one of those is positive, that's a symptom, and then it will be considered diagnostic. And generally, or if you had an abnormal finding on your mammogram and they want you to come back and do an ultrasound or a second mammogram to do compression views, then that's considered a diagnostic test and your deductibles will apply. And so that's where we get a lot of confusion. It's like, well, it's a mammogram. My insurance is supposed to cover that. Well, they'll cover screening mammograms, and there's a difference between a screening mammogram and a diagnostic mammogram, a screening colonoscopy and a diagnostic colonoscopy. But if you're not sure, that's what to ask. Other questions? Everybody? Yes.
I'll ask you one more.
Yes.
Maybe a wind up. What should we be doing to keep ourselves out of the doctor's office?
Well, that's, that, it's a lot harder than it sounds, but like any of these cancers that we talked about today, maintaining a healthy weight, eating a diet that's heavily plant-based, getting regular exercise will reduce your risk of every single one of those cancers. Easy, right? Like exercise every day, become a vegetarian. But it's true. Every one of these cancers you're at increased risk for people who are obese, who have a Wisconsin diet, heavy in meat and cheeses and things like that. Excess alcohol consumption will increase the risk of every one of those cancers. I know. Like living in Wisconsin is in itself a risk. What risk factors do you have? I live in Wisconsin.
Thank you, Dr. Rita.